Today we're going to talk about endodontic therapy on a 5-rooted first molar tooth. What is the reason that so many dentists are so afraid of endo? I don't know. Endodontics is one of, if not the most predictable procedures in dentistry if you know how to do it. I have no tie to real-world endo and Brasileir, but we've been teaching that system in my teaching center, CARD, the Center for Aesthetic Restorative Dentistry, for the last 10-15 years. And these rotary systems are wonderful, and they're almost fail-safe if you just learn how to use them and use them correctly. I'll average probably at least a couple of endodontic procedures in my practice every day. Though it's something that the patients really appreciate if they can have the endodontic procedure and the crown done at the same time and not have to go to another office. And it's a very productive thing for you, the dentist, and handy. Say you're doing a big restorative case and there's one tooth that's hypersensitive. It's such an ordeal to send them out of your office to an endodontist. If you can just do it right then, while you're prepping crowns and doing the other things that you're doing at that appointment, it's so much easier for the patient. And as I said, a very productive and predictable situation for you. We're going to talk about the key points in successful endodontics today. We're going to talk about access opening and how important it is that the coronal part of the pulp chamber preparation is flared so that you have direct access to the canals. Remember, if the access is not direct and you're trying to really clean it out with some medium to larger size files, those are the ones that separate if you have a big curve. So we want direct access, number one. Number two, we're going to talk about these wonderful files called scalp files. They're fantastic in identifying little tiny canals that are hard to find and accessing the apical part of the canal. We're going to talk about irrigation. I use 3-to-1 sodium hypochlorite with water, 3 parts water, 1 part sodium hypochlorite. I want to say that again, 3 parts water, 1 part sodium hypochlorite. Some endodontists use straight sodium hypochlorite. Others, endodontists, have told me they use 5-to-1. Others use a mixture of chlorhexidine. I've found the 3-to-1 water to sodium hypochlorite to be very effective over the last 35 years. So, learn how to do endodontics. It'll be a very nice addition to your practice, both for the patient and for you. You see, we have an abscessed first molar requiring endodontics. First, use the DEXIS dental imaging system with a measuring application to determine the length of the root. And you can see that the approximate length of the palatal root is about 17.5 millimeters. Now this is just a general measurement, so you're in the ballpark when you begin the endodontic procedure. The access opening is made with a 330 carbide burr. Now, as I'm using the burr, I'm trying to flare the orifice so we have direct access to the canals. Now, I'm just barely cutting through the roof of the pulp chamber. I'm not taking the burr down to the floor of the pulp chamber, because if I did, with a high-speed handpiece, there's a high probability you could perforate the floor of the chamber, which is not the end of the world, but you'd rather not do that. I'm just removing most of the roof of the pulp chamber with the 330 carbide. You can see the nerve is still intact. I'm returning with a number 6 round burr on a slow speed, and as I use the round burr, I'm lightly placing the burr on the floor of the chamber, and then once I engage the burr with the rheostat, I'm pulling the burr coronally. I'm not pushing it apically, because again, you could perforate the floor of the pulp chamber. So you're The motion is touch and up, touch and up, touch and up. This is a straight, sharp probe just identifying the canals. And in this situation, we had 5 canals. This is a wonderful, wonderful tool. It's a scalp file, very flexible, very small, and I use this often to identify small canals. And that's what I'm doing here. I'm not necessarily trying to get to the apex of the root. I'm taking this very tiny, flexible scalp file, and you just move it across the floor of the pulp chamber, and it will dive in to the little tiny canals. I probably wouldn't have been able to find all 5 of these canals without the scalp file. See, it just dives into those canals. This is a critical part of an endodontic procedure because periodically you are going to separate a file in a canal. It's going to happen. The literature shows if a file is separated in a canal, it's not the end of the world. It doesn't mean the tooth is going to have an issue or be lost if you've cleaned out the apical part of the canal. So before you start with your rotary files, other than the scalp file, use these number 10 K-type and Hedstrom endo files to the tip of the apex of the canal so you clean out all the debris. The thing that causes, the primary cause of a tooth having problems or being lost after file separation, when that does occasionally occur, is the nerve is not, and debris is not cleaned out of the apical part of the canal. So you want to do that with these K-type and Hedstrom files prior to using another file, rotary file, other than just a enlargement file or the K-type file. We'll talk about that here in a minute. But the main thing here is use these little K-type and Hedstrom files to clean out the debris in the apical portion of the canal with sodium hypochloride in the canal. Then if a file should separate, it doesn't mean that the tooth will be lost, and you don't necessarily have to remove that separated file. You can see I'm cleaning these out. Now I'm using the apex locator to determine the length of the canal. In a perfect world, the measurement on this apex locator, again, this is a Brasileir product. I don't have anything to do with Brasileir. It's just the one I use. You'd like this measurement right here to be 0.5. Now you'll notice on some of these measurements, I may take a measurement at 1.0 or even 1.5 and remove the file and not take another measurement, because what I'm doing, or what that's allowing me to know, is that if this said 1.5, then when I take that file out and I've got the rubber stopper, if I measured that length to say 16, if this number was 1.5, I would extend the length to 17 millimeters. You don't necessarily have to move it and then put it back in the file. The objective of the apex locator, and you're using a K file in the canal, a number 10 K file in the canal. So the objective of the apex locator is to allow you to know where to stop filing, what the length of the canal, the working length of the canal is. You see, this is 1.5. So when I remove this, I'm going to add a millimeter. That's at 18, so I'm going to add a millimeter, which would make it 19. And here we go into all the canals, 0.9. So in that case, I'm going to add about a half a millimeter to the length, the measured length, to the rubber stopper of the file. So that one was 17, so I'll make that one 17 and a half. And I'm identifying the files again with my sharp probe. Then this is the scalp file. And now this time with the scalp file, I'm measuring the actual length of the canal as determined with the K file and the apex locator. This is full of sodium hypochlorite. Now I dilute the sodium hypochlorite 3:1 with water. Now there's 3 parts water with 1 part sodium hypochlorite. Some people use the sodium hypochlorite straight. There are different theories on this. I've heard of another endodontist told me that he used 5:1 water to sodium hypochlorite. It's just a personal preference. I've never had any trouble diluting it 3 parts water to 1 part sodium hypochlorite. The reason I personally like that is just in case any ever leaked out into the inferior alveolar nerve canal, it wouldn't be a real problem. Okay, so I'm going to length with these scalp files. Then coming back, I like to come back with a Hedstrom file and just clean it real well. Once we've determined the length, come back with a Hedstrom number 10 hand file and just clean the canal very thoroughly in the apical portion. Now I'm taking another measurement here. I get 1.5. So in that case, it was 19. The measurement was 1.5. So I'm going to extend this to 20. Taking another measurement here. And so I'm right on the money at 0.5, and that canal, whichever one it was about 13. That was probably a mesial buccal canal, or a MB2. MB2, yeah, 13. Now, after you've determined the length of the canals, most of the time I use a Real World Endo Brasileir medium file set, which is file sizes 25 to 40. I'll begin with the 40 file, rotary file. You can see it's a pretty large file. I'm not extending it very far into the canal. Just the coronal, maybe 1/5. And the only thing I'm trying to do is enlarge the coronal opening so that, for the main reason is so it can hold sodium hypochlorite. As you're filing, you want to keep the canals lubricated with sodium hypochlorite. So this creates a little cup for that sodium hypochlorite to fit into. So I'm going to start with the 40, which is a larger file, and with very light pressure, I'll push till I meet resistance and pull it out, push till I meet resistance, pull it out, push till I meet a little resistance, pull it out 3 times. Now, if it's a larger canal, you may be able to extend all the way to the bottom, to the apex of the canal, like a palatal and an upper molar, or a central incisor, or upper central incisor, or a distal canal of a lower central incisor. But the main thing is don't put much pressure on the file. Don't let it bind, or you could separate the file. Now the good news is, if that ever were to happen, it's not a disaster because you've already cleaned out and irrigated the apical portion of the canals with the number 10 K type and Hedstrom files. Now I'm dropping to the number 25 file. And again, with very light pressure, I'm moving it up and down in the canal 3 or 4 times. If it binds at all, pull it back out. Then I'm going to go to the 35 file, the file just smaller than the 40. And what I'm doing is what called crown down. That means you enlarge the coronal part of the canal first, so it will hold the sodium hypochlorite irrigation liquid and Also, it's making the access to the apical part of the canal more open, so you have direct access and you're not having to go around the curve. Just light pressure. Now I'm going back to the 30 file. This sodium hypochlorite, now I put this in a 10 cc syringe, just a normal syringe with a normal large tip. You're not placing the tip of the syringe in the canals. That's very important. This liquid is not placed under pressure. You just squirt it into the open part of the pulp chamber and let it flow down into the canal, but don't put the tip in a canal with pressure, or you'll inject it past the apical part of the tooth. It's just as a loose, non-pressure delivery solution to dissolve the nerve particles left in the canal. Now this is a 30 gauge short needle with just local anesthetic. And again, I'm not putting the needle into the canal. I'm putting it right at the coronal orifice of the canal and squirting it with no pressure, just to float anything in the canal to the top. It's a terrible mistake if you put the syringe into the canal under pressure, either one of the syringes, the sodium hypochlorite or the local anesthetic syringe, both for irrigation and to help with debridement. If you put them under pressure, it's just very loose, and you squirt that in, and anything in the canal comes to the top. The entire time that you're filing the canals, you want to be sure that the canals are very lubricated. So what I'll do, I'll irrigate between each file, and then I'll just drip some sodium hypochlorite into the pulp chamber, so that when the files go into the canals, there's lots of lubrication. Just verifying the canals. So this one had a palatal, 2 distals, a mesial buccal, and an MB2. And I probably wouldn't have found them all if I hadn't used the Scalp File. It's interesting, for years I didn't use the Scalp File. I didn't really know about it. And then we had a seminar at my teaching center by Real World Endo, which we have about every 2 years, and the presenter was talking about the Scalp File. It really changed my life. It's a wonderful instrument. Okay, these are the Guttapercha cones. Now some people use a size smaller Guttapercha cone than your last file. It was very interesting to me to learn that the objective of filling the canal is not necessarily to fill it with Guttapercha, it's to fill it with sealer. I'd always thought it was to fill it with Guttapercha, and the sealer was just kind of the cement between the bricks. But we've had 2 endodontic presenters saying that the sealer is the main thing, and the Guttapercha cone is just to push the sealer into all parts of the canal. So most of these sealers are generally, especially in the smaller canals, one size smaller than the final file. Cutting those off, and then we'll take a radiograph to confirm that the links are correct. See, all the links are good. Now, what generally causes a file to separate? Usually, the access is not directly into the canal. In other words, you haven't flared the coronal opening of the canal enough, of the pulp chamber, so you're trying to go into a curved canal like this, and the file will separate right there. So as much as you can, you want the access into the canals to be straight line. You can't always make that happen, but be really careful if you have a larger file and you're having to curve it. Those are the ones that break most frequently. So I'm lining these up so I'm sure to get the right Guttapercha cone in the correct canal. I'm irrigating again with sodium hypochlorite, again not with pressure, just in the pulp chamber, then coming back with the 30 needle and just irrigating in the pulp chamber part of the tooth, not poking it into the canals under pressure. No pressure. And anything in the canals will float to the top. It'll float to the pulp chamber. Oftentimes, after I've irrigated with my local anesthetic, usually Sitness plain, and the 30 gauge syringe, I'll come back and take my air syringe and just very lightly blow the pulp chamber part of the endodontic procedure to get rid of the liquid that's just sitting in the canal, that's just sitting in the pulp chamber. We'll come back with the paper points and I'll use the largest paper point that I can place in the canal. Now you notice this palatal canal had a little bleeding. What do you do in a case like that? Take a large paper point and place it in the canal and just leave it there while you dry the other canals, and that will generally stop the bleeding. What if you have a little bleeding and you just can't contain it? Go ahead and fill the canal. Go ahead and fill the canal. Okay, so I'm just leaving this one in the palatal canal while I dry the other ones. And that pressure will normally stop the bleeding. Now if it's a little bitty canal, I'll squirt the Endo Sequence BC sealer on the actual Guttapercha point and not directly into the canal. Why? That volume of BC sealer in the canal could cause the Guttapercha cone not to go to length. So I'll just place it in a small canal on the actual Guttapercha cone. Put that to place and move it up and down just a little bit. Now the larger canal, I'll go ahead and squirt some of the BC paste into the canal. Move it up and down just a little bit to be sure you've got good coverage. This is a Guttapercha cone cutter. Very handy. It's just a heating element. And I'll sear it off and then I'll touch this Guttapercha just a little bit just to soften it and come back with a plugger and plug it into the canal just a bit. This is another smaller canal. BC paste, move it up and down. Larger canal, I squirted the BC paste into the canal and I'm moving the cone up and down, cutting them with the Guttapercha cone cutter and then just softening the material in the canals just a bit, just softening that Guttapercha and then plugging them with a plugger. This is IRM and I'm placing this with a football-shaped instrument that's wonderful for that. You can also use a cotton tip applicator. So there we have it. 5 well cleaned and filled canals.
Thanks for joining us on this week's episode of the Dental Minute. Make sure you subscribe right here and right now and join us next week. We will be talking about bone grafting and membrane placement. You won't want to miss it.